This is North Dakota Legislative Review on Prairie Public. I'm Dave Thompson. Thanks for joining us. Our guest this week is State Senator Judy Lee from West Fargo. She's a Republican and also chairs the Senate Human Services Committee.
Right.
Senator, thanks for being here.
Thank you for the invitation.
Your committee has a lot of heavy lifting this time.
We have, absolutely. But my committee has really stepped up, and I'm very proud of them all.
And you said something during a debate on the Department of Transportation bill today that I found very illustrative, that there was talking about closing some of the maintenance offices.
The state maintenance shops.
And you said that you could not support that because of all the other needs out there, and it's a very tight budget.
That's true.
And I'm paraphrasing what you said, but you know, human services is a huge budget item, and there are a lot of needs and there are a lot of demands. How do you sort through all that?
Well, there's been a fair amount of pain involved with the changes we've had in our financial situation, because with the allotment, which was very necessary, we get that. But the human services budget lost $54 million, and there's no way you can cut that kind of money out of a budget and not have some things go away or be reduced that you really wanted to have in place. We've worked for years to get them to a certain level, and the idea is that some of these things would be incrementally moved along, like some of our behavioral health programs. So sometimes we just have to make a lateral move. We just hope it's not too far back.
So at this point, it's the money is not there for what you'd like to do at this point.
Well, one of the examples is that we have a need to do the best funding that we can for those people who are living in skilled care facilities, whether it's basic care, skilled care, or assisted living. But there have been reductions in the funding that were supposed to start now in January. They were delayed with the allotment. But not only is it a moral issue that we properly support the folks who are vulnerable adults really living in these facilities, but there are federal and state staffing requirements we have to meet as well. So this is really a crisis for some of these facilities, well, all of them, if we are not able to step up. So we're trying to figure out how to do that, but that's part of our challenge for the rest of this session, is how we can find the money someplace to make sure that one area in particular is funded, but there certainly are others.
I know there was talk, and of course there was, in budgets was this provider assessment, which could have been up to 5%, but that seems to be off the table right now, or is it off the table?
Well, as far as I'm concerned, it's off the table, and here's the reason. North Dakota is one of a handful of states that has what's called rate equalization, and that means that if a member of your family is in a long-term care facility on their own money, because they have been fortunate to be financially successful, or they've saved and been careful, or they have family members or whatever, they're on their own money. And if I have a family member in there who has not had the same life circumstances and doesn't have the money to pay their own way, they would be on Medicaid. They need to get the same services. So the state, before I even came to the Senate, passed legislation that says the rates have to be equal. So whatever the Medicaid rate is that's reimbursed by the state of North Dakota, the private pay patient cannot pay more than that. So what's happened is a triple hit to the long-term care facilities. They had a reduction in the Medicaid rate, which meant they have a reduction then called for in the private pay rate they can charge, and there's a reduction in the federal match because we have a 50-50 match from the feds for our Medicaid money. So they have really taken a nasty hit with this.
Is this something that you think you can solve? Is a solutions being talked about?
Oh yes, all the time, absolutely. But this, my view of this provider tax was that it's an end run around the law, which is rate equalization, and I support that concept, and I would hope that we don't have to do anything to jeopardize that.
I'd have more, there are a lot of issues before your committee, but there's one that really you're dealing with right now because I think you're under the gun to get the bill out, and that's what's going to happen with medical marijuana.
In fact, when I leave here, we're going back to, I hope, finish that up for our part right now. But yes, we absolutely understand that the voters want to have medical marijuana available. Excuse me. But the initiated measure that was passed was a cut and paste effort from several different states and absolutely unworkable. The really big deal that nobody noticed in what some people think is a perfect document is that they didn't bother to decriminalize marijuana. So you could grow it and you could buy it, but if you possessed it, you would be a criminal. So one of the big things in the bill that's being considered, 2344, will be to deal with that issue, to make sure that somebody who possesses medical marijuana will not be charged with a crime, even though federally, of course, it's still a controlled substance.
Yeah, and that's where everything gets a little bit murky because you've got the federal say it's still a Schedule I drug,
Absolutely.
and you have the states saying, well, and states are now adopting laws to have medical marijuana, so there's a conflict there, and then you had the conflict that if it wasn't solved by the amendment that you have about decriminalization, you would have had a
Exactly.
crime in North Dakota. So there are a lot of moving parts to this.
And we don't know what the new federal administration will do, whether or not the new Attorney General will go back to enforcing that federal law about it being a forbidden drug, or will they continue to look the other way? I should mention, though, that there are several things on a list for those states that have implemented medical marijuana that the federal Attorney General's office is not focusing on giving a lot of static to the states that meet certain criteria in that area, which we are trying to do with this bill as well, so that we will be able to manage that. So we're trying to set up a structure that the health department can handle, that we can afford to do, that will make the product available in forms that people can use, that we protect children, not only children who are taking this, whose parents want them to have it, but children who might be in a home where a marijuana product is consumed. So there are a lot of moving parts to this bill, you're right.
One of the things that I hear from the proponents of medical marijuana is they didn't like the original bill because it didn't allow for smoking marijuana.
Well, and we're looking, that's part of our job this afternoon, is to look at some latitude there. But quite frankly, if we just let it go the way it was in the initiated measure, everybody could grow it and smoke it and do whatever, and it would be everywhere, and there would be a proliferation that would absolutely be a terrible challenge for law enforcement. They're not quite sure how they're going to handle all this as it is, because some of the other states, Colorado in particular, has a really awful situation going on in so many ways. And we are trying to implement something that can be done strategically in the fashion that that it's workable, that it does what the voters wanted because they want it, and we're doing our best to provide that. But that it won't be wide open because it's much harder to bring things back, but that it will enable a structure to be put in place that we can actually pay for, that the health department can manage, and make it available in a variety of different forms.
And another argument against it, the bill that was introduced, was what some perceive as very high fees for compassion centers, for grow operations, or for distilling operations. But the amendments I've seen kind of reduce those fees.
Yes, they are. And actually, they're quite comparable to other states. And we have to have a way to make this self-supporting after this biennium. So as this moves forward, if there are, perish the thought, more people who get into marijuana use, but as it moves forward, if there are more people than what we're estimating, and the health department's doing its best, but we have no data to really help us with that, the fees could be reduced because the goal is to make it self-sufficient, but not into a moneymaker.
Yes, and well, that makes sense that you have it pay for itself eventually.
Yep, we have startup costs right now, and there will be some state funding in there to help with that. But ultimately, it'll take about a year to get everything in place. And then there will be a year during which fees can be collected from the manufacturers, which can grow and manufacture, and then from the dispensaries, who can dispense. One of those cannot do the other function. There have to be two separate entities for that.
Now, this just came to me just now. Is there certain reciprocity? So, for example, if California has medical marijuana, can somebody come from California to North Dakota and bring medical marijuana with him or her?
Only if they have dealt with a North Dakota physician.
Okay.
In a face-to-face meeting is what we're looking at having it be, so that there isn't some kind of, not so responsible physician somewhere who's got a heck of a good internet business. But so that if it's really medical, then we need to have a physician who's licensed here, who indicates that this individual has one of those conditions for which this treatment would be an acceptable treatment for their symptoms.
Would it be safe to say that the state wants to err on the side of caution while still providing what voters wanted?
Exactly, and we're trying to come to a good balance there. We really do know that our obligation is to implement it. But as it was written, I would be willing to bet a very nice lunch that most people who read 5 or 6 lines on the ballot did not read the 35 pages or so of the initiated measure. So when they think they know what they voted for, they're thinking about what they voted for, but they don't necessarily know what they voted for.
Okay. So this bill will help clarify that
Absolutely.
as much as you can.
And we want the public to know the reasons why we're doing each of these things and what our alternatives were. And the alternative to a 2/3 vote in both houses is that we would go back to the initiated measure, which would be almost impossible to implement at all.
Now that brings the interesting point, because you need a 2/3 vote because it's amending an initiated measure.
Exactly, because the legislature's always very reluctant to overturn something that the voters have put in place. And that's why this is a big deal for us to look at doing it this way. But because it can't really be done the way the measure was written, we have to have, it certainly points out the importance of us having an agreement among the various legislators in both houses to come to some consensus, because we have to have a 2/3 vote both in the House and in the Senate, and a governor's signature, of course, in order to override the initiated measure.
But if I were betting too, I would bet this would be a fairly lively, spirited debate on the floor.
It could be, but this has also been a very bipartisan effort in the Senate working on this, and we've put in a fair amount of time, and we've had wonderful assistance from the Attorney General's office and the Health Department and law enforcement and a variety of players who know more about it than we do. So we know it's not perfect as it leaves the Senate, when it will this week or next week actually. And there will be other amendments in the House, I'm sure. They will have another discussion about it. So this is not over. I'm pretty sure this is going to end up in a conference committee in one of those last weeks of the Senate, of the legislature.
Would this be a conference committee one would like to go to hear the discussion?
I think people might be interested in hearing about it, absolutely. So it'll be something I would hope that news organizations will cover as well.
Now, when we talked about it earlier in the session, you did talk about incrementally getting this bill in. And I think if you get this amendment through and you see some problems with it, well, you're back in 2 years.
Exactly. And we have, as I mentioned, it's going to take about a year to set this up. I mean, as soon as they're able to do it, it will be done. But in most states who have passed medical marijuana, it's been 18 months to 3 years before something's been set up. So this is a pretty remarkable fast track that's on.
It's a truncated track.
Absolutely. But we know that's the whole benefit of having another legislative session coming up. We will have 1 year of experience with it. We'll be able to see what works and what isn't, and it can be fixed so that the wishes of the voters will be implemented in the best possible way. If we mess it up, then it becomes harder to fix as bad things get in place. Inappropriately addressed things get in place.
If I can then switch gears to a couple of things. Number one, what's the status, and I think it's probably still over in the House, of the Medicaid match?
I can't answer that, I'm sorry. I'd rather not tell you that answer, but we are, the FMAP, the Federal Medical Assistance Payment, is the FMAP, and we have been at 50% for a long time now. That's because our economy is strong. And if we were in a really bad economy, then we would have more money from the feds, but I'd rather have a strong economy. There are states that get 80% from the feds and 20% from the state. And I did ask one of the people in OMB once, or actually in the Department of Human Services, where would we be if we didn't have this 50% floor? And we would be at about 32%. So we're happy that there's a 50% floor.
That 50% floor, that's the lowest.
That's as low as the feds will go right now. I mean, they can change everything too, but that's the way it's been for quite a while now. So that's good for us because we've been able to count on that 50% floor, which at a time like this is a critical thing for us. I don't anticipate them seeing that our economy is in such a downturn that match will increase. We can't count on that at all. We're still doing pretty well.
I assume there's still a little bit of angst about the Medicaid expansion that was passed 2 years ago to be part of ACA. And there are attempts in the federal government to repeal ACA. And what happens to the Medicaid expansion at that point? There seems to be a lot of questions about that.
Well, and we were really looking closely at that. I was a supporter, and I still am, of expanded Medicaid for several reasons. One is we have about 20,000 people or so that are now insured that weren't before. And not only does that mean they're getting health care, but here's the big deal for the provider side, they're getting paid. Otherwise, any of those hospitals that received Hill-Burton funds for their construction some years ago are obligated to serve anybody who presents at the emergency room. So they have a lot of uncompensated care that they have been subject to absorbing. And for our critical access hospitals, our 36 smaller hospitals in the state, it was a big hit for them because they don't have any of the high cost procedures. They're not doing heart transplants, you know. They have a lot of Medicaid and Medicare patients that are in rural areas, older populations. They will move to specialty areas for medical specialty care. So we were subsidizing with general funds on a regular basis some of these critical access hospitals to keep them open because they're important to the health survival all over of the state. So our choices are now, of course, with the Affordable Care Act, and I don't want to call it affordable because it really isn't, but the the payments that are coming in, excuse me, have been 100% federal up to this point, and now it'll be a 10% state match. So that gives people some heartburn. However, I think we're better off with a 90-10 split than we are with 100% general funds to be able to keep these critical access hospitals open, because that's our option. There's no choice C that says it won't cost us anything any place.
So you're caught between a rock and a hard place almost.
Pretty much. So I think we have a responsibility there because we have to assure access to health care throughout the state. And these critical access hospitals do a fine job. They don't have a big census each day, but they really do provide excellent care. And as a sidebar to that, I have to put in a plug for our wonderful emergency medical services. They are truly the angels of this state. These folks are volunteers, almost all of them. And if you think about it, volunteer crews in any area of the state are serving neighbors and family members. When they get an ambulance call, and this happens, not only might it be somebody they know, but it might be a member of their family that's in that accident. So we have to give them a tremendous amount of credit for helping us to provide good access to care throughout the state.
I want to talk a little bit about behavioral health and what steps are being made in North Dakota in this session toward putting more, community-based treatment in place, things that the Schulte report talked about in the 2013 biennium. And the state has moved, I'll call it incrementally, and maybe not as fast as some people wanted, but what do you see coming out of this session in terms of behavioral health?
Well, one of our biggest projects has been Justice Reinvented, and I'm sure you're familiar with that, but I'll mention a little bit about it for the viewers. And that is on a niche of our citizens who need to have treatment, but it's for those people who are being released from incarceration, because then they can move into the community with community supports, including peer support, and be able to return to society without the risk of recidivism being so high. And we are moving that forward. I have an example of a young man that I visited with last session, and he was a felon, is a felon, I guess, and he talked about how frustrated he was because he had gone to apply for a job in a local business, and he was told he had to be clean for 7 years and out of prison for 7 years before he could apply. Well, that's a long time. Then there are only a couple of apartment buildings in the city where he lives that will accept anybody with a felony on their record, so the people who are released are all living with the folks they knew in prison, which isn't necessarily going to be the greatest social environment. So they can't get a job, and they're all clustered in the same place to live. And so they start using drugs again, and they end up selling them because that's how they're going to get some money just to live. And that's a rotten way to have this cycle keep on going. So we're looking at a variety of ways to do that. Leanne Birch, who's director of the Department of Corrections and Rehabilitation, and Pam Sagnes, the director of the Division of Behavioral Health for the Human Services Department, have worked very closely on this, along with Dr. Lisa Peterson from the penitentiary, to develop programs that we hope will be very effective in helping our folks who are released from incarceration, jails and prison, that can return to the community and not be returning to be imprisoned again. And of course, for everybody who cares about numbers, and we all do, it also should mean we should not have to build so many additional beds. If all of the jails and the penitentiary additions are completed that are either already under construction or are being proposed, we'll be increasing the number of beds by 48%. Now that's terrible. So we're not, bad dudes should not be let out. I mean, as one of the speakers said this week, we should be locking up the people that scare us, not the people that make us mad. So it should be angry, but never mind about that part. But anyway, what we need to do is make sure that those who are dealing and selling are certainly going to be expected to have consequences for their actions. But those who have been possessing a drug, for example, there are women in the women's prison who are there for 6 years because of possession, far away from their families and their children. And so being able to see them is hard because most of those individuals live in the eastern part of the state. That's where the people mostly are. and they're not able to really connect with their families well, and it makes it very hard to come out and not have services. So that's one small niche, but we're also looking at expanding the workforce. We've done several bills having to do with the various boards of licensed addiction counselors and social workers and psychologists and all of those people to streamline that process a bit, and also to work with higher ed to make sure that we can do a little adjustment of curriculum to have more people that might be able to come in.
And you hear judges even say that sometimes they feel they have to sentence people to prison because that's the only treatment available. So there is really a
There's a
need
crisis
for
here.
treatment. Yeah.
70% of the judges have said that they have sent somebody to prison in order to get the treatment they needed. And a very, very prominent physician in North Dakota said 100 years ago, we used to send people with mental illness to the state hospital. Now they end up in jail. That is not an improvement. And we need to think about that.
Yeah, the idea of institutionalizing people has never really been, at least in modern times, it's not been all that popular or all that effective.
It's just not the way to do it. If we can help people remain in their communities, closer to their families, able to be employed, and close to services for addiction counseling or whatever other kinds of things that they need. We have over half of the people who are incarcerated who have either an addiction problem or a behavioral health problem or both. If we can help fix that for some of them, that's a really good thing.
I know this is more on the justice end of it, but do you see where the state might be looking at easing up on some of these mandatory sentences too?
There's discussion about that going on in the judiciary committees. And so that's true too. And before we move on from that subject, I want to mention that we're also looking at another end of the spectrum, and that's children's treatments as well. We need to make sure people are aware of the fact that even children as young as 0 to 3 need to have interventions in situations where they are struggling with some kind of behavioral problem, because they end up having trouble in school then and they aren't learning. And that's just a very bad cycle for them to get into. They end up then in the criminal justice system.
So this is going to take a little time to really solve or really get a big bite at the problem.
Right, and a big part of it is workforce. So I'm recruiting addiction counselors and all those other counselors.
And you see the cities like Fargo, Bismarck, Grand Forks might be okay in terms of addiction counselors, but it's maybe the smaller cities like a Dickinson, Williston type thing.
We are short of them everywhere, but it's a critical issue. I was told, and this is some time ago, so I can't guarantee that it's true today, but that if you drew a line from Bismarck to Minot, there's one psychiatrist west of that line. That isn't even close to our need. However, there are some innovative things that we can do with telehealth. We have some of the specialists who are working in some of the bigger cities who are involved with treatment. It isn't all going to be that way, but that people can catch up real regularly, also with people who might be on that career ladder, so that they might have somebody that is diagnosed and has a treatment plan with a psychiatrist or a psychologist, and a social worker or an addiction counselor or someone can make sure with more regular appointments that they are there to touch base with that individual.
And of course, as all this is happening, then comes the opioid crisis.
Oh my goodness, yes. And I'm very involved with those projects in my home area, and it's certainly a big deal here too. We're trying to do all that we can, and that we're back to addiction counselors again. But the old saying about we've got to quit just hauling the babies out of the river. Somebody's got to go up on the bridge and catch the troll that's throwing them in. We have to look at prevention. And ironically, the Department of Human Services has wonderful programs for parents and schools and the public in general that's available to them. Just go on Parents Lead, Google that, and you'll get what you want. But there's never been money in the budget for marketing, so it's a sort of a secret agent deal. We want people to know that there are good contacts that they can make for excellent programs that don't cost them any money.
So are you hoping to get some money toward marketing?
Well, we're looking at everything we can do in that regard, absolutely.
So again, it comes down to some money issues.
There's a lot of it that is related to money.
But you have to be creative to solve some of these problems.
Right. But there are things that we can do that don't require money, and we're working on that too. And there's a program tonight by a local group that has a program in which there will be discussions by Representative Kathy Hogan and by Pam Sagdas from the Department of Human Services, in which they're going to be describing in much more detail than I have what we have been doing and what we still need to do. So we invite people to go to the center, the Energy Center at Bismarck State College for that.
So briefly, we are doing a lot of things.
We are really, yes. We just haven't tooted our own horns very well.
And you're hoping maybe if this word gets out, maybe even word of mouth might help.
Well, and anybody who really wants to get a hold of any of their legislators certainly can do that. But I'm happy. I answer I answer messages from anybody. They don't have to be from my district. So if somebody wants more information or is interested in being involved, we have over 400 people around the state involved in our behavioral health task force. And we do our meetings by conference call. We distribute information through email and the website at the Center for Rural Health, the behavioral health link. There is a ton of information there, and we invite people to check that out.
Okay, now just a very brief answer. There was talk about keeping 10 days. Will the legislature be able to adjourn in 70 days?
I never thought we could, but we're looking better.
Sounds good.
We might make it.
Okay. Senator Lee, thank you so much.
Thank you. I appreciate it.
Our guest today on Legislative Review, State Senator Judy Lee from West Fargo. She is the chairman of the Senate Human Services Committee, a committee that's been doing some heavy lifting. For Legislative Review and Prairie Public, I'm Dave Thompson. Thanks for joining us.